Easiest place to start would be maybe anything that anyone's heard about Neuro Clinic, the ketamine services, the TMS, neurofeedback, or any questions that might be coming up about neuro services.
Do they have to have a doctor to come in? Because I did have a couple of people that wanted to come to the neuro clinic, but they need a psychiatrist. They don't have services whatsoever. Is it possible for them to come to the neuro clinic and see our doctor?
That's a phenomenal question, actually. So there must be a doctor involved, and the doctor that is involved, if it's at this site, must be attached to this site specifically. So that's for Spravato. That's for our ketamine service. And just as a reminder, Spravato is going to be the intranasal version of our ketamine. We do not offer IV ketamine.
Yeah.
Those are similar in structure. There is some differences. Too much into the science behind it, but once someone comes into our clinic for intranasal ketamine services specifically, they get seen by our doctor. They go through an initial psych eval, and upon getting formally recommended by that doctor, then they can. Now, for outside patients, which might be a part of this question as well, as of right now, the situation is that they should be enrolled in our IOP PHP as well if they want to start neuro services. But great question. Anything else that we've heard or questions we may have?
So with the ketamine treatment, like what are the qualifications for having somebody start that? Is it the same as like TMS where they need to fail 2 psych meds first, or like when do we use it?
Absolutely. I love that question because it ties into all the variables that are at play. So for both TMS as well as for Spravato, and this is also why I like to differentiate, because this is not the case with IM or IV ketamine. Those are all prescribed off-label. Spravato has specifically been developed for treatment-resistant depression, the same thing that TMS is designated for. There are some small differences in getting insurance approval for these different modalities. Like for TMS, for instance, I've had a patient who was recommended to try ECT first. A lot of that comes back to the fact that TMS is a procedure, whereas Spravato is a medication that's being purchased from a specialty pharmacy. So when patients come in for TRD, generally the knowledge within psychiatry right now is that they've tried at least one medication, and they have tried psychotherapy before, and it has not worked to a satisfactory degree. So this is the generally accepted definition of what would require somebody to come into either Spravato services or TMS services. The issue here, though, is that the only insurance company that actually honors that is Medi-Cal. So depending on what other insurance company a patient is coming in with, they have their own requirements. So some might say it's 2 medications of any odd class. Some might say it's 4 medications of 2 classes. Some might say it's 4 medications of 2 classes plus 2 augmentations of 2 classes. So there's variety there. But the best starting point is going to be to know that the patient has tried medication before. It didn't provide them with satisfactory results. And it's also helpful to know if they've also been in treatment before, and how that went, right? Because if they're in treatment, then it's kind of entailed. There was both psychotherapy involved previously, and there was also medication involved previously. Yes. Great question. And I want to stress again, that would be totally different than what we would see in like a IV or IM ketamine. For a lot of patients, I think that is a little bit of a surprise to them coming with Spravato. So we essentially have a organization above us first. That's going to be REMS. We're going to have to check in with them, go ahead and get their prescription validated. Once that's complete, then we have to go do a separate authorization. For most IM ketamine, IV ketamine situations that patients might be referred to, they're being prescribed off-label, right? So there's not this oversight that takes about a week for them. More than likely, well, 100% of the time from what I've heard, it's done through cash pay, right? So it's going to be a little bit of a different type of setup from the get-go. TMS, though, the good news is that if somebody's been approved for Spravato, more than likely they've also been approved for TMS. They're both targeting the same thing, right? They're both working on TRD here. So we do have the options, if we get it now for one, to go to the other. At this moment, as of right now, we are accommodating the Tri-West TMS. And we are also doing that for our cash pay residents as well. For our RTC residents who are interested in the services, we begin compiling their documents once they're in RTC. And then at the point of step down, we go ahead and actually reach out to process that authorization. Should the patients, of course, still want that service, whether it be for Spravato or it be for TMS. Now, that's all like regular stuff, right? It's pretty commonplace throughout all of the ketamine clinics. What makes us different, though, what makes this clinic is what I call our complementary services. So we have TMS, we have Spravato. These are like our interventionary services, right? Somebody's going through a psychiatric disturbance. They have tried medication. It's very much a clinical psychiatric intervention, right? But to complement these services, we have two forms of biofeedback on the table as well. So one of them is going to be neurofeedback, as we use through a company called Brain Pain. Really the standard. I have my own opinions about how up to date they are, but they really are the standard when it comes to clinical treatment using a neurofeedback device. On the flip end of that, we also have another form of of biofeedback called vibroacoustic therapy. So I don't know if anybody is familiar with like Hertz frequencies, different pitches, using music kind of to regulate different neurochemicals. So we're harking on that technology big time here. So anytime anyone is enrolled into our Spravato services specifically, generally, if you go see other clinics, the process is really kind of gross in a certain type of way, because what they do is they stick people on what I call chicken coop, and they put on a TV and they give them their phone and they're like, okay, here's your 2 hours and then you're done. Right? What we're doing instead is we're kind of removing those. So we're creating like situations where patients can go into insight, right? So we don't have any phones around. We have Bluetooth headphones, right? That are connected to playlists that the patients specifically pick for themselves in their individual treatment. The first hour, they're very sedated, but after that first hour is when we actually start our integrative services, what I'm talking about that kind of separates us. So after an hour of Spravato, a patient can either hop into neurofeedback or they can do VAT. Now, VAT, like I said, it is strictly a biofeedback device. It has a lot of technical clinical application, but practically it's essentially massage, right? So who wouldn't want that after an hour of being stuck in your head, right, on end? So we offer that to every single patient enrolled in our Spravato services, and we actually integrate it. Once they do that for an additional 20 minutes, then they come back to their journal. So we've kind of spoken to Janssen, they've helped us out, and they have kind of acquired these very specific journals, kind of detailing notes for their healthcare provider, what their experience was like on this session, and what they would want to see that's done different the next time around, right? This is not where it ends there. That's just treatment day. Day number 2 is where we really go into, and this is the beauty of having an IOP attached to it, right? Is they are all enrolled into integration sessions with their therapist, right? So they have these very deep experiences that are coming up in the moment. There's not much human-to-human contact. Instead, we are trying to have different modalities, right, to kind of soothe whatever may be coming up. The following day, though, they're able to go into a therapy session and really kind of get some semblance, get some meaning behind what is going on. So that's kind of in a nutshell. Now, if we have a second, I would like to kind of show what it looks like. Okay. So the room we are in right now actually is going to be our first individual room for Spravato. I'm not sure if this is showing up clear. How's it looking on there? Can we kind of see it? So this is going to be our individual Spravato room. So we have patients at Lindley, right? We have patients that are coming from Lindley, I should say. We have patients who have very high acuity, right? I mean, this treatment is already for patients who have high acuity, but when they're coming in here, sometimes maybe being around people is not the best thing in this moment. I'm kind of giving you an eyes view of what the patient is saying for the 2 hours. It's pretty trippy, right? Once they are in this room, though, they have access to their own Bluetooth. There's someone checking on them 15 minutes at a time, right? And they also have access to the brain pain. So like a room like this would be for the patient who enjoys their ketamine service, but then they also enjoy a neurofeedback at the same time. And we get really interesting results with that specifically, because what the brain pain is doing is it's also in real time tracking how long someone is stressed out for, how much of their attention is being used, and all of these different things, right? So that's going to be our first individual room. And as I said, that's going to have the brain pain attached to it. Now, similar, but a little bit different, this is going to be our second individual room here. And what's making it different is that this one instead has what I've been talking about this whole time. So this is our VAT device. Now, embedded within this daybed looking thing is a series of speakers going across where someone's spine would be if they're laying down, right? When these speakers, and these are specialized speakers, they're called transducers. When these transducers are connected to the playlist that we have specifically for this, all of the music coming through them is going to be between 300 and 450 hertz. What that does when applied to this machine is that it causes the body to interpret those sensations as sounds. At the same time, there's also sound being played that's perfectly synchronized with it. So in essence, what we're doing is we're hijacking the patient's attention. Do you see what I'm saying? They've been in their head for the past 40 minutes to an hour, and now we're bringing it back into the body, right? So this is going to be our VAT. Again, for a very acute patient, maybe they've been in a trauma house, maybe they're having a hell of a week, right? Whatever the case is, they cannot really be around 6, 7 people at one time. We have this individual room set up for them as well. Okay. And we have our little water fountain. Now, for most of our patients, right, for our general community here in outpatient, we have our Spravato community room. And if we look in here, we can see we also have an additional 2 beds there. But this is really where most of our outpatient patients are going to be getting their Spravato services. Alexa, pause, please. And so as you can see, the idea completely is comfort here, right? So you can imagine someone who's depressed is also very anxious, let alone they're trying an entirely new treatment modality that they only really hear about the news usually, right? So there's going to be some anxiety in there. So that's why we've kind of specifically used the colors and the setting that we're using is to alleviate that a little bit. Any questions about any of this stuff as I'm kind of walking through and going room to room here?
No, it looks amazing.
Thank you. And of course, last but not least, let's flip it around. We have our TMS chair. So we have a very special type of TMS too, I must tell you. So TMS, there's like 3 waves of it. There's the original TMS, transcranial magnetic stimulation. That's usually about 40 minutes to 60 minutes, right? Then you have the second generation, which is RTMS, repetitive TMS. That was about 20 to 40 minutes, 20 to 30 minutes, depending on the protocol, right? What you're looking at here, this is the TBS system. TBS stands for theta burst stimulation, right? So I said the TMS was 40 to 60. The RTMS was 20 to 40. This one does the whole thing in 3 minutes and 7 seconds flat. Okay. And not only does it do that, but the same company that we're using here, MagVenture, they've actually employed this exact same model device at Stanford. Stanford has now released their clinical trials and results for what they call the SAINT program. SAINT stands for Stanford Accelerated Intelligent Neuromodulation. I can't remember the T, but what they did was they took that same 3-minute protocol, they extended it for 9 minutes, right? And they found 80% response in treatment-resistant depression symptoms in 5 days. So this does it the 3 minutes over a 30-day basis, 5 times a week. The same protocol found in about 5 days. That's been FDA cleared. There's a new piece of technology though that we haven't really asked for that protocol because there's going to be a new what we call neuro navigation site that's coming. And what that does is in live time, it's going to give us a QEEG of the patient's brain, showing us exactly where their afflicted area is, right? Right now, we're not guesstimating, I don't want to say, but we use specific measurements. So you can imagine how revolutionary it's going to be when you can see that in real time, right? And that's kind of what they've harked on for the Stanford Accelerate. But everything that's being delivered is being delivered through this. This is going to be the magnetic coil. So there's an electrical pulse. That magnetic coil is emitting it. And what's going on is it's specifically stimulating nerves at the surface of the brain. It feels, I don't know if anybody's ever tapped you on your shoulder, if you know that sensation, but that's essentially what it feels like at most. It's some patients are a little bit, how do you say, like, they don't really like the look of it, right? It might be a little bit intimidating. That's why for everybody, we actually have a second coil where we offer them almost like a mock shock, you could say, on their forearm, just so they can feel exactly what it's going to be like. So those are, like I said, our 2 interventionary services and our 2 complementary services. But yeah, that's the full gamut.